So I'm Ravi Thevasagayam. I'm an ENT surgeon in Sheffield. It's a great pleasure and honor to speak to you today about a topic that I kind of got interested in about 8 or 9 years ago, and that is inducible laryngeal obstruction. So what are we actually talking about? Well, what we're talking about is a condition in which people feel like they're choking or become acutely breathless, and it comes right out of the blue. And it seems to happen in the context of a larynx that largely works normally. That's the key. It seems to occur at two specific sites. One is at the level of the vocal cords, and the other is at the level of the supraglottis. So in one sort of group, there seems to be a chordal closure problem, so a bit like a cord palsy, and the others, it seems to involve the supraglottis, which is the tissue above the larynx, a bit like laryngomalacia might in a baby, although in this case, it tends to more involve the epiglottis more commonly. And the condition has been around for a very long time. It was described over 100 years ago, actually, in a paper in '74 by Patterson. He called it Munchausen's stridor, which gives you a flavor of what people were thinking at the time. The idea that this was really people who were a bit crazy or putting it on. But the link between emotional well-being and psychological health and this particular condition that causes stridor was really well established and has been for decades, really. But the condition really hit the mainstream in 1983 when Christopher published his very famous paper in the New England Journal of Medicine, which was a case series of 6 or 7 all women who were actually healthcare workers. They're all nurses, and they had what he described as asthma that was not responding to therapy. And he realized that the problem wasn't their lungs or bronchoconstriction, but was seemed to be obstruction occurring at the level of their larynxes. He actually thought that it was he thought it was an illness of healthcare workers, funnily enough, because that's who's happened to all be nurses. But and all of them had had some kind of significant psychological trauma, like a sexual assault. And he actually thought it was essentially a somatization illness, that is a physical manifestation of a psychiatric illness. And then since that time, there have been lots of different papers describing this particular clinical entity, a clinical entity when people who are otherwise fit and well, otherwise seem to have normally functioning larynxes, suddenly developed obstructed breathing that seems to happen at the level of their larynx or their supraglottis. And what's made the subject really confusing is it's had so many different names over the years. Now, in North America, they tend to call it paroxysmal vocal cord movement disorder. In this country, the term that you may well have heard is paradoxical vocal cord dysfunction, or just vocal cord dysfunction. That's a term that I'm glad we're not using anymore, because the vocal cords don't really go paradoxically. And why would they? I mean, why would your vocal cords go literally in the exact opposite direction that you wanted them to do? That would be a strange thing for them to do. But in 2013, and then I think subsequently in 2015, a group of clinicians got together and published a consensus statement in which they said, look, let's stop calling it different things. Why don't we come up with one single term that we can all use? And the term that they came up with was inducible laryngeal obstruction. So hence the title of this talk, even though that term really hasn't entered the vernacular either here or in North America, but that's the term that we're meant to be using. And I think this is a big step forward, actually, and I've kind of gotten used to it. And I think it'll make the literature much easier to understand, because hopefully everybody will be publishing papers and we'll be calling it the same thing. What they suggested was that because inducible laryngeal obstruction, or ILO, tends to have a trigger, we would name it using the trigger as the prefix. So for example, if the trigger was exercise, then that would be EILO, exercise inducible laryngeal obstruction. Interestingly enough, in that paper, they didn't, although they came up with a name, they didn't come up with a definition. And weirdly enough, nobody has. But you get the idea based on what I'm saying, I hope. So inducible laryngeal obstruction, or in the case of exercise, it would be EILO or ILO. That's the term we're also meant to be using. And hopefully that's going to be very helpful as we try to make sense of the literature going forward. Well, how common is it? Well, interestingly enough, these guys in Sweden did a population study, and they sampled by questionnaire over 3,500 adolescents. They took everybody in Sweden who had been born between a certain group of years and sent them a sample, and then they sub-studied in real detail about 146 of them. and they found a prevalence of 5.7% in the adolescent population, which is extraordinary. It's incredibly high. And so it gives us a sense that this condition is out there, and it's more common than we really realize. That's all I'm really saying with this particular slide. EIB is exercise-induced bronchoconstriction or exercise-induced asthma, and they had it in that group at about 19%. And that's probably kind of our sense of it. If you know any adolescents, asthma or some kind of asthma is pretty common out there. So, and these conditions coexist as well, so they can occur together. So as I said, I got interested in this and have been seeing children in a specialist clinic now, and I've seen over 100 kids, and I know I spent 90 minutes with them. It's quite a long session, and I've come to the conclusion that there are two very distinct clinical entities in pediatrics. In the adult world, people don't tend to fit into quite so clear binary way, but in the children they do, I think. And this has been really helpful because as I've learned more about the pediatric disease, I've become found it much easier to spot the adult disease. So if you keep these two clinical entities, understand that this is not an established kind of classification, but it's just my reflection based on the fact that I've seen a lot of kids with this. And it seems to me that in pediatrics particularly, children fall into one of two groups. They either present with acute severe dyspnea. A child will suddenly become acutely breathless. They get rushed into ED, they're on oxygen, all sorts of stuff. And everybody thinks that they must have either a severe status asthmaticus, an asthma attack, or some sort of terrible airway condition that's an airway emergency. Or children tend to present with exercise intolerance. So they exercise, and as they start to get to the peak of their exercise, they become breathless. And everybody thinks that they have exercise-induced asthma. And so when I see patients in the second group, they've almost always been on asthma medication, because that would be the obvious thing to think about. As I said, in the adult world, because of the way that people modify their lifestyles and the way that people understand and have health paradigms, it's not quite as clear cut. But if you have these two distinct groups in your mind, as you talk to adults, you'll start to recognize these patterns occurring, although in the adults, there tends to be a less clear-cut binary division between the two presentations. So the first group, I'm going to call them teen angst for want of a better term. There's a pretty strong female preponderance, typically an adolescent female, often an exam year, often highly strung, highly pressured individuals. And again, they present with this acute dyspnea. But the key to recognizing this condition in this group is that they have stridor without hypoxemia. So in other words, when you see them in an acute setting, although the picture is incredibly dramatic with work of breathing and loud stridor, and they appear to be tiring, if you look at their numbers are not terrible. Typically, their oxygen saturations are being maintained. Typically, if you did a blood gas on them, you'd see that their PO2 was normal or high, and they'd be blowing off CO2 because they were hyperventilating. The other interesting thing about this group in the acute phase is that when they're asleep, they tend to become quiet, which is not the normal pattern for anybody with an airway obstruction, where, for example, in sleep disordered breathing, people tend to get worse when they're asleep and they lose their tone. These kids almost inevitably become quieter when they're asleep. And this presentation can be so dramatic that tracheostomies are described in the literature. We've seen a couple of children at Sheffield who've come to us intubated from a referring hospital. In Sheffield, there were a couple of adults who would routinely get intubated. One lady, I think, who was intubated about 7 or 8 times, because each time they presented in this way, it was so dramatic that the clinicians treating them just couldn't really believe the values for the blood gases and the oximetries that they were looking at, and decided to proceed to intubation. You could see why, because if you see these patients in this acute phase, it's extremely dramatic. And then the second group, in the children of the young athletes, that's the group that I have developed an interest in. I treat them; they're super fun. Here, there's an equal sex distribution. They tend to be aged between 8 and 11, and they tend to be all-rounders, high achievers. Kids who are good at everything, good at their studies, good at sports, and often heading into becoming an elite athlete. They are kids who are often playing for schools or counties or local clubs, and may even be thinking about doing this as a career. That kind of level is the children that we tend to see at Sheffield. Often intolerant of personal failure. This is kind of a trait of athletes at the top end. It's one of the things that drove them to excel in their sport. Often they strive for external validation, whether it's their coaches or their parents. That seems to be a common theme. And what's interesting about them is that there's often an increased competitive level as the trigger. It's sometimes hard to spot it. You have to dig quite deeply into the history to get to it, but it's not uncommon to recognize that there's a point at which the level of competition became harder. And what's interesting about these kids who are good at a certain sport is that when they started it, it was effortless for them. They were playing against kids who weren't great. They were just killing everybody, and then they get picked out to play for their school, and then they get picked out to play for their county or for Team GB or whatever. And at each stage, there are these sudden jumps where suddenly they're competing at a higher level against a whole bunch of kids that are also extremely good at their sport. And then at some point, somebody might say something like, oh, well, this kid might represent our country or might become a professional footballer. And suddenly there is this incredible weight of expectation, and it doesn't happen gradually. They often happen in these very specific steps, and it's not uncommon for us to identify a specific trigger. And the children themselves are conflicted, because obviously this step up was everything they ever wanted. So they find it hard sometimes to make the link between that and their increase in symptoms. One of the first patients that we ever treated at Sheffield was a young girl, a teenager who was playing for Sheffield Wednesday girls, and she got scouted by an American college who offered her a college scholarship, or thought she might be in the running for a college scholarship to go to the US, something that would be worth tens of thousands of pounds. And her symptoms triggered just about that time. And that was because something that had started as something that was effortless and fun suddenly became harder and that much more consequential. So this increased competitive level thing is something that I try to dig into, and it's not uncommon for me to spot it. So in Sheffield, we developed this clinic that we run jointly with respiratory, and we do this in a respiratory lab that's got a treadmill. And the way the consultation works is that we have a consultation with the family. There's quite a lot to get into in terms of the history, and I really try to drill down into the history, and I'll specifically focus on the very first time it happened. You often get the most information from that episode, the point at which they went from having no symptoms to having symptoms. And I spent a lot of time really trying to dig into exactly what happened. Of course, they get breathless, but what's the exact sequence of events? You learn a lot about that. What else was going on around that time? What else was going around in their family and what they were thinking about? We'll do heights and weights and spirometries. And then this is one of the key investigations that we do. This is called a light scan breathing analysis. This machine sends a checkerboard pattern onto the patient's front. And what we're doing is that the machine is analyzing the movements of the checkerboard to give us an understanding of how this child breathed at rest. And after about 3 or 4 minutes, it produces a reading of their breathing at rest. This is a couple of examples. So in this picture, you can see that the blue represents abdominal breathing and the green represents thoracic breathing. They're meant to go together, of course, and they do, as you can see, blue and green lines going here. And this is a patient who's breathing in time. Their diaphragm, their intercostal muscles, they're all working together. This chart refers to thoracic breathing on the y-axis and abdominal breathing on the x-axis, and you can see straight down the middle, this patient is breathing using both their diaphragm and their intercostal muscles, and there's a good link up between their thoracic breathing and their abdominal breathing. This representation is a bit like a flow volume loop, and again, you can see very consistent. Every breath looks just like the next breath. This patient over here has got a condition called dysfunctional breathing. It's a pattern of breathing in which the breathing is just not very efficient. And it's not efficient in this case because they're not really using their abdomen, which is really a marker of their diaphragm. They're not using their diaphragm. All of their breathing is happening up here at their chest. If you can see on this chart again, all thoracic. There's a disconnect. This is known as thoraco-abdominal asynchrony. And again, the flow volume representation you can see is not consistent at all. This means that each breath is different from the last breath. And I'm going to go into in a bit more detail why we think in Sheffield this condition happens. And we think to some extent it happens because of this largely inconsistent breathing pattern. If you think about it, when you take a breath, what's meant to happen is that your diaphragm moves down, it pushes your abdomen out, and then your intercostal muscles contract to lift your ribs up and out. And at that moment, as you're drawing air in, your vocal cords move out of the way. They know to do that, obviously. And this is an autonomic function. You're not trying to do it on the conscious level or at the somatic level. But if your breathing pattern is extremely inconsistent and variable, you can kind of get a sense that your vocal cords might not really know where they're meant to be in space and time with regard to the phase of respiration. And it's probably not inconceivable to think that at some points when your diaphragm is moving down or your chest wall is moving out, your vocal cords might get caught in the middle. And in that situation, they might actually obstruct your breathing. And that's, I'm going to develop that idea as we go through this talk, this idea that at the heart of inducible laryngeal obstruction is really a mismatch between the way that we're breathing and the way that our vocal cords think we should be breathing. So this patient on this side of the screen has got a condition called dysfunctional breathing. Just take my word for it, that is a thing, and I'll develop that idea in a minute. So the next step is we do a standard flexible fiber optic laryngoscopy. That's what this is. If I run the tape, you can see his epiglottis is kind of retroverted at rest, which might be playing a role. We know that laryngeal obstruction Oh, he went from 11 to 14 there. Maybe that's a thing. But that all seemed pretty normal. And that epiglottis that was retroverted actually then flipped forward and didn't seem to be causing a problem. So far, so good. Everything normal. Then the fun part, we'll get them on a treadmill, try and get them working as hard as they can. Our respiratory consultant is watching their heart rate monitors. And I'm shouting at them to try and get them a bit stressed out. And we're going to try and push them as hard as we can in the hope that we're going to be able to trigger one of these attacks. So it's basically a provocation exercise. We want to get them up to maximum capacity. What's great about the heart rate monitors as well is it gives us a sense of their level of fitness. So we know that they're not going to get out of breath because we've pushed them past their fitness level. And by and large, these kids are super fit anyway, so that's never an issue. So what we'll do is we'll exercise them to the point of an attack, and then as soon as that happens, we'll scope them. In the adult world, particularly on the continent, they are working on, and also in fact in the Brompton, they're working on doing continuous readings of the larynx through the exercise. But in children, by and large, we felt that this is the way we're going to do it, and it's worked out pretty good for us. So we get him to the point where he has an attack, then he jumps off the treadmill and we put the scope in again. So he takes a deep breath and his cords come together. So you get a sense of what's happening there. I'm telling him to take a deep breath in, and when he's trying to take a deep breath in, it feels as if his cords are coming together. And you can see why somebody in that situation, when they're really gasping for air, would really feel like they're choking. Their vocal cords, which should be moving out of the way, are actually coming together as they're trying to get a deep breath in. And so that you can imagine that's kind of upsetting and just feels like choking essentially. So that's what it looks like in practice. In this particular case, it was all caudal, but we know that these patients tend to have caudal and supraglottic, or a combination of the two. So in Sheffield, I'm so sorry, this is an old slider. We're now up to over 100 patients, but you can see, yeah, we had slightly more girls than boys. And in this group of patients that have been selected, we only had about 5%, 3 patients in that group who had asthma, but they can coexist. Within this group, a certain number have nasal obstruction. We think the nasal obstruction is kind of relevant in this case because if you've got a blocked up nose, breathing through your nose is a potent vocal cord abductor. And so if your nose is blocked and you breathe through your mouth, then you're kind of not going to have that effect. And so that might prompt predispose you to caudal closure. Also, breathing through your mouth is not a great idea anyway, because it tends to dry your larynx out and make it more irritable. And so if they've got a blocked nose, we try and address that if we can, whether it's through intranasal steroids or septal surgery or adenoidal surgery. It's the nasal obstruction is not the main problem, of course, but it's just one cofactor. I'm going to talk a bit about how I think these cofactors play a role, but we'll tackle nasal obstruction. If kids have reflux or adults have reflux, it's certainly worth dealing with that. I think reflux probably plays a role in that. We know that there are pretty potent reflexes that promote caudal closure in the presence of acidity at the lower esophageal sphincter. This is largely a protective mechanism. And so if you've got reflux, then it's worth addressing that. These young athletes, it's surprisingly common in them for a number of reasons, I guess. Sometimes it's just due to their lifestyles. They're running around, bolting meals down. They sometimes come back after training and have a big dinner and then go to bed. That's not uncommon. Sometimes their sport predisposes them to it. So swimmers, for example, because they spend a lot of time prone in the water, will be prone to reflux. And we have actually a sports physio in Sheffield that works really hard with swimmers, trying to improve their core strength to try and keep their acidity in their stomach. And we'll talk a lot about their diets, talk a lot about how they're doing with their diets, talk a lot about whether we can amend their lifestyles to improve their reflux. And of course, reflux acid suppression is definitely an option. So then there's this question again that we've known about for a long time, that emotional well-being and emotional health play a role in this condition. We've known about that for well over 100 years. So the question is, well, how does your emotional well-being cause stridor? Well, if you think about it, if you go to any relaxation class in the world, the first thing they're going to ask you to do is to breathe deeply. And they may well ask you to do this. They may well ask you to put your hand on your abdomen and get you to push against your hand on the in-breath. What that's doing really is it's engaging your diaphragm. And for some reason, diaphragmatic deep breathing is intensely relaxing. Every relaxation therapy in the world starts with this. But what happens when you get anxious? Well, when you get anxious, you start to breathe in a very shallow and erratic way. And so unquestionably, for hundreds of years, we've known that the way that you feel affects the way that you breathe, and the way that you breathe affects the way that you feel. And so we shouldn't be at all surprised that our psychological health has an impact on the way that we breathe. We've known about it forever. So what actually causes this? Well, at this point, I'm just going to offer up a disclaimer to say that this is my view, and this is the view of us in Sheffield. It's not the mainstream view. But last year we published in Frontiers of Pediatrics our idea that inducible laryngeal obstruction was actually a subgroup of dysfunctional breathing. And dysfunctional breathing, if you remember, was that idea that at rest you weren't really breathing in an efficient kind of way. This condition is actually surprisingly common. There are papers that suggest that up to a third of all men and 2/5 of all women have some degree of dysfunctional breathing, which is probably going to be just fine unless you're exercising or making increased demands on your airway. It also explains the link between psychology and mental well-being and ILO, because rates of dysfunctional breathing amongst people who have anxiety conditions, neuroses, is extremely high. And so at rest, again, their breathing pattern is erratic and shallow. And then when they exercise, they're more likely to have their vocal cords move out of phase with their breathing. So this is the mechanism of disease that we propose in Sheffield. Again, my disclaimer is that this is not the commonly held view, but it's the way that I understand it. We think at the heart of this is this condition called dysfunctional breathing. We think there are these enhancers, these factors that seem to promote the genesis of this condition. So asthma is one of them, reflux is one of them, rhinitis, partly because it promotes a mouth open posture, and partly because if you have postnasal drip, we know that's a potent caudal closure causer. That's again a protective mechanism. Certainly poor vocal hygiene, dehydration, these are all things that promote caudal closure. So we think that these things create the environment for ILO. And then we have the triggers, and the common triggers are emotionality. So we think that's probably a big factor in the type 1s that I call type 1s at the start of this talk. Irritants, smells, this is quite big on social media and stuff, although we've not seen very much of that in Sheffield. And then exercise, that's a big group. And then there's something called a shift event, which I really won't go into today unless it comes up in the questions, but it seems to be a trigger that at which point a patient's level of anxiety will cause them to attempt to try to over-control their breathing or over-control their caudal movements, something that you're really not meant to do. These are autonomic functions. They're not really meant to be dragged into the realm of the somatic. And we think that shift event is what triggers a mismatch in the phase of respiration. So, and that gives you ILO. So we don't think your cords are really closing as such. They're just out of phase. Your caudal movements are out of step with the way that your respiratory chain is working. That's the underlying kind of mechanism that we're proposing in Sheffield. So how do you treat this? Well, first of all, I should say that although we have a specialist clinic, I think the vast majority of these patients can be treated without that. I feel like our specialist clinic is for really the people who are not responding to any treatment. And certainly when I see patients in the adult world, mostly what I do is make the diagnosis and reassure them. The key, though, is that you have to have confidence in that. Remember, these are people who think they're going to choke to death. Okay, so saying something like, well, almost certainly nothing serious going on here, isn't really that reassuring to somebody who thinks they might choke to death. And so you have to have a certain degree of confidence in your diagnosis. And you can be confident once you've established the pattern and once you've established the inconsistency of their performance. And I spend a lot of time talking to patients about this. If one day you can run 10 miles and another day you can only run 10 feet, and then the next day you can run 10 miles, then that inconsistency is completely incompatible with a structural airway abnormality. There's no structural airway diagnosis that does that to you. So once you establish the paroxysmal and inconsistent nature of the airway performance with all of the other things that I mentioned, you can be 100% certain that you've got the diagnosis right. And so you've got to be completely clear that you understand the diagnosis, you're making the diagnosis, and you understand that they're not going to choke to death. It's helpful to rationalize their asthma treatment. If they don't have asthma, it's helpful to stop the asthma treatment because the inhalers may be irritable on the larynx. I think if they've got reflux and nasal obstruction, by all means treat it. In Sheffield, for children, breathing therapy is a key thing, trying to move their breathing at rest into a more efficient paradigm so that when they then exercise, they cope better with it. Working on vocal hygiene is big. I'd spent a lot of time talking to my adults about habitual throat clearing and coughing. They're extremely unhelpful. And then again, if there is a strong psychological anxiety element, trying to unpick that is a big deal. I try not to get involved with that, but I try to put it on people's radar that this is something they need to think about. If they're under stress, you can't stop people from having stress, but what you can do is encourage them to mitigate it, to think about how they're handling and processing their stress. So in other words, whatever it is, whether it's relaxation therapy or journaling or hypnosis or yoga, but they need to understand the link between their anxiety level generally and their symptoms regarding their breathing. And so that strategy of mitigating that stress is a must-have rather than a nice-to-have, I guess, is one of the ways I put it to patients. There's a lot of centers that are doing a lot of surgery for this, but because I fundamentally believe that this is a timing issue, I don't do a heck of a lot of surgery. We've only really operated on about 3 larynxes, and the surgery that we do was epiglottopexy. But by and large, we think that if we can get patients timing their breathing better, this condition gets better. So surgery is not a big feature of our treatment in Sheffield, although I know it is in other centers, particularly in Scandinavia. This is a leaflet that actually one of my patients was a GP gave me. It's on the Royal College of Speech and Language Therapists website. You can point people to this. It's kind of helpful. It talks a bit more about the condition and gives them some general advice about vocal hygiene and kind of gives them an understanding of what might be going on. And there's a lot of information out there. In fact, one of the key things about this diagnosis is that once you've told people what it's called or its various names, then they can access a lot of this stuff online. There's a Facebook group, I looked at it today, 4,500 members. They're still calling it VCD. So just by all means, give them the synonyms. But there's tons and tons of information out there for people to use and access themselves. So in Sheffield, we're doing pretty well, actually. We have 100% of patients that we've treated have reported improvement in their child's symptoms based on the PedsQL quality of life reporting. So we think we're doing all right actually with our approach, even though we're not doing much surgery for them. So in conclusion, well, a multidisciplinary approach is great, but again, I don't think you really need it. If you're prepared to take a solid history and do a basic examination, you can help a lot of people, particularly by making the diagnosis. Because one of the keys to this is that the more anxious you are about breathing, the more dysfunctional your breathing becomes. And the more dysfunctional your breathing becomes, the worse your airway performance, and the worse your ILO, and then the more anxious you become. And so breaking that cycle is really about making the diagnosis and reassuring patients that you know what they've got. It is a thing. There's a lot of information out there about it. And once people realize that they can't choke to death from it, because nobody has yet, you've made a big jump in moving them towards improving their function. And finally, yeah, the response to therapy is great with the return to normal function, the expectation of treatment. You can't say that about many things we treat, but in ILO, particularly the type 2s, the athletes, we've managed to get all of them back to the level of fitness and sport that they wanted to get. We've had a couple who kind of fell out of love with their sport because of all of this, and so they didn't particularly want to go back. But every single patient that we've seen who's wanted to get back to sport at a high level has got back to sport at a high level. And so I encourage you to treat these patients. They're a lot of fun. There's quite a lot to unpick sometimes, but the response to treatment once you've made the diagnosis is universally excellent, I think. Maybe you can't see that because of the screen, but you can see some of it. Again, this is just one of our patients who's a swimmer who's done very well. It is great actually working with young athletes. They're a fun bunch of kids. They're super engaged. You know, in pediatrics, trying to flex scope kids is never fun. These kids are all up for it. Putting up with temporary discomfort for long-term gain is just hardwired into them, and it's a lot of fun, and it really is has been a real pleasure to treat these kids in Sheffield for the last 8 or 9 years. So thank you very much indeed. I hope that was helpful and I didn't confuse anybody, and I think we're going to go into questions or comments, but yeah, thank you very much indeed.
So, I mean, I think you touched on this. I think someone just wanted a bit of clarification about when you do the exercise laryngoscopy, how you do that. I think you'd said with the kids, you stop them exercising and do it straight after, but could you maybe just talk through exactly the process of that, and do they jump off and sit down, or how?
Yeah, pretty much. So yeah, the actual exercise test is called a modified Bruce protocol. It's what they do for asthma. It's how they provoke asthma attacks, and then yeah, basically there's me, the respiratory physiotherapist, and the respiratory physiologist, and yeah, we with this chair right by the treadmill, and as soon as we think they can't go any further, we try and push them as hard as we can. We just kind of manhandle them into a chair and I throw the flex scope into them. That's how it works. And sort of bearing in mind this is a pediatric clinic, we've not had a single patient that we didn't manage to scope. We've had a couple of ice skaters actually; they were quite a challenge, but by and large, young female GB ice skaters. But by and large, we've scoped every single patient that's come in, and nothing terrible has happened. It's great.
What's the youngest kind of age you've had, Ravi? Did you?
So from memory, I think it's probably about 9, which is, you know, you're on reasonable territory there, I think, with the flex scope. But again, as I mentioned briefly in my talk, particularly athletes, I mean, they just want to compete, and so they'll do anything really they see this as their lives, and you tell them you're going to do something unpleasant to them that might make them a bit better, they're all up for it. Yeah,
and is it right to think it tends to be more kids kind of into teenage years, or just before that? You've not been referred any much younger than that?
No, and I think once you get below that age, then you're much more likely to be dealing with a structural problem, or maybe reflux is a much bigger issue. But that age, and of course, yeah, adolescence, prepubescence, puberty, that stuff, you know, suddenly the world becomes a whole lot more complicated for a teenager on an emotional level. And so yeah, we see a lot of kids in there. But you know, we've seen kids who, it turned out one kid who had a bereavement reaction, that never mentioned it before, and came out during the consultation. So anyway, but yeah, prepubescence and pubescence, that's the group.
Great. Thanks, Yakubu. Is it okay if I just go through the couple of questions in the chat, and then I can see you've got your hand up, and I'll invite you as well if that's all right. So I think Ishan said, do you tend to involve paediatric psychologists in many of the for many of the children specifically?
Yeah, so that's a great question. So we do, but you know, I mean, I don't know how much experience you have of dealing with CAMs, but pediatric psychology services are basically trying to keep kids from killing each other or killing themselves. And you know, they are incredibly stretched. Our kids basically want to swim a bit faster or run a bit faster, and so I kind of have to accept that. You know, they don't particularly want to see these patients because they're just too stressed out about it. So, you know, I point them in that right direction. Certainly kids who are on their way to professional sport will invest money in it and see people privately. There are ways of accessing counseling out there, but within our trust, I kind of have come to accept that it would be great to have a clinical psychologist. In North America, all the teams have one. It's a massive part of it, but we just have to accept that in Sheffield, CAMS and clinical psychology and psychiatry services are just too stretched to deal with this particular sub-cohort of patients. I think I just have come to accept that.
Thank you. Oh gosh, lots of people are adding lots of questions. Yeah, this was something else I wanted to ask you. It sounds like your clinic predominantly focuses more on the exercise group of the two groups you talked about, and someone was asking about how you investigate or treat the group that present with these sort of acute severe stridor. Do you see those as well, or is there a slightly different pathway for them?
Yeah, so I do see them as well, just by virtue of the fact that I've dealt with so many of the type 2s, and we will sometimes bring them into the clinic even if we don't exercise them, because you know there's 90 minutes to spend with somebody is a real luxury in the NHS, and so we'll sometimes bring them in even if we don't run them, or we'll just make it a pure asthma test essentially, just to see how much asthma is involved. But with them, again, a lot of it is just spending time. If they're in patients, trying to get inside their heads and try and figure out what's going on with them. And you know, the approach is just much more making the diagnosis. And incidentally, one of the reasons that I think it was helpful that the term paradoxical vocal cord movement isn't used is that actually it's very rare that it is completely paradoxical. I showed you a case of it, but actually that's unusual. Often it's much subtler than that. And I suspect that a lot of people have assessed these patients, not seen paradoxical movement, and dismissed it as a diagnosis. So I think a lot of it is on the history, but for those patients, it's really about trying to figure out what else is going on in their lives and try to point them in the right direction and try to make the link for them between that. And occasionally we have ended up doing an airway examination on a general anesthesia just to rule it out. We just know that the history gives you enough reason to think that maybe there is something else or a cofactor. Again, some of these patients do have a cofactor that might be a structural problem that might be contributing, even if it's not the whole story. And so occasionally we'll do an airway examination on them just to either rule it out or rule it in.
Yeah, okay, that makes absolute sense. And then Fiona has asked, yeah, because your focus a little bit is that you think the fundamental underlying issue is the breathing, maybe rather than laryngeal function being more secondary. Is that why you tend to focus more with respiratory and breathing as the treatment rather than having more of a speech and language therapy focus in your clinic?
Yeah, so again, and partly it came about just because me and Nikki kind of developed an interest in it, and she's fundamentally a breathing therapist. In the adult world, and I think in most units, it's really a speech therapy. It falls within the realm of speech therapy. But as you know, again, in Sheffield, our speech therapists are trying to stop kids from aspirating. And again, this isn't really their bag in the same way. So, but yeah, it just happened that we ended up getting interested in it and I went down this road. But I have come to the conclusion that, again, this is more of a timing issue than a true laryngeal condition. But so yeah, I think it's a diaphragmatic condition, not a laryngeal condition, if that's helpful.
Yeah. Yakubu, you've had your hand up for a bit. Do you want to ask your question?
I joined you a few minutes late, so I'm not sure whether you've talked about the management in adults. There are some of these severe cases whereby the first speech therapy, I don't know what your experience are with Botox injection into the thyroarytenoid muscles in some of these cases, whether you've had cases that will require that in the adult group if you deal with adults as well?
Yeah, so in fact, funny enough, I've had a couple of, actually, I should have said that my results are great in kids. In adults, it is more complicated. I have had some good results, but I've had a couple that have really been incredibly difficult to treat. After I've got a medical student that's incredibly difficult to treat. But yeah, no, I don't have, I know that Botox is used, it's in the literature. I've not had experience of using it. Have you, Yakubu?
Yeah, there are some of care patients that have to do Botox, and actually they do respond to that very well. And I think for cases that needs to keep coming back for Botox, you may need like a laser of the thyroid muscles as well, would help minimize this inspiratory stridor that they have instead of abducting during this. So just small amount of Botox, like 1.5 units on each side. And I've had some patients that were able to extubate them from the ITU because usually they come at night time or during the weekend or odd hours to the A&E and they get intubated because nobody knows what's going on with them for safety reasons. So some of them will inject them in the ITU and then they get extubated about a few days after that.
Okay, well, that's great. Yeah, I definitely will start looking at that more. I have done some supraglotoplasties on them, and that kind of helps, but it also pretty hairy post-op, but because all kinds of strange things happen and not always hard to understand sometimes. But but Botox is in the literature for this, so and it's good to speak to somebody who's been actually using it and has had good results. Brilliant.
Thank you, Yakubu. There's a nice comment, Ravi, in the chat from Shoma Ganguly, who says, could you do the talk again for the benefit of District General Hospital paediatricians? I think they refer to your clinic dysfunctional breathing service and have seen a very good response. I think felt it would be useful for you to talk to a wider paediatric audience in the future. So I'll leave you to see if you can arrange that.
Thank you. That's really kind. And I think the key to this condition is just spotting it. Once you've spotted it, and made that diagnosis, I think lots of other things follow from that. So yeah, brilliant. And we have seen more awareness of it in our local region. Certainly we get referrals from our own respiratory team and from our nearby hospitals. So yeah, I'd love to. Thank you.
And I think the final question in the chat was just a little bit more detail about when you do kind of advised breathing exercises, is it your respiratory team within the clinic who kind of go through those, or do you refer to someone else like a speech and language therapist to implement those? How does that work?
Yeah, so Nikki Barker, we're really lucky actually. Nikki Barker, who I think some horrible London hospital is trying to poach at the moment, is our breathing therapist. She's in the clinic. She's a massive interest in this. She typically offers patients between 4 and 6 sessions, and she works on them. And again, she has two stems to this. One is to get their breathing at rest out of dysfunctionality, and then obviously strategize them for how to cope with their acute episodes. So and all of that stuff is online, that how you cope with acute episodes, which is largely to do with controlling your breathing, slowly breath through your nose, all this kind of stuff. But one of her focuses is, and she does a lot of work on posture as well. Posture is a big factor in terms of the way people breathe. So yeah, between 4 and 6 sessions they get to work on their breathing. In the adult world, and probably in most of the units, it's largely a speech therapy thing. But for children in Sheffield, we've largely been doing it as a breathing therapy thing. But in Sheffield, the adults, respiratory and speech and language therapy deal with it.
Great, thank you very much. I don't think there's any more questions in the chat. Does anyone else want to put their hand up or any final questions? I think most of the ones in the chat were the things that struck me. Can I just, it's a slightly small thing. I was really interested in the study that you described. Was it in Denmark with quite a high reported symptom? I don't know if you can remember, Ravi, or when you last looked at it, so I don't want to be unfair, but I just wondered how was that just self-reported kind of symptoms that the teenagers had described? Because it seemed really high to me, although like you say, maybe it just is much higher than we would expect.
Yeah, so what they did was, they did they identified every single person born within a group of the years that would make them adolescents, basically. And then, yeah, send them all a questionnaire. It sounds like in Sweden, if you get a questionnaire, you fill it in, and then you get an appointment to go to a hospital, somebody stick a scope down you, you just turn up. And so it was remarkable. And then they randomly selected 150 patients out of the pool of whatever it was, 3,500 patients.
Yeah.
Now, in that pool, fairly about, I think it was something like 2/3 did say that they had exercise breathing problems. So it might not have been a completely representative sample, because they may have just hit that group, or in fact, but actually, if you think about it, if you think about how many kids walk around these days with inhalers, it does seem like a fairly common thing, doesn't it? So, but that was the way they worked it. They looked at 3,000 or 4,000 questionnaires, picked 150 patients, and then studied all those in detail with the full works in their clinic. And these patients who were picked at random just evidently pitched up and spent hours and hours getting examined by these guys.
Hello. Hi, Ravi. Thank you very much for an excellent talk. I'm a speech and language therapist that works in the severe asthma service at Guy's Hospital, treating these patients with laryngeal dysfunction as a part of the MDT. I just wondered what your thoughts were on, like, would you in your assessment clinic routinely do a laryngeal, like a palpation assessment, just to feel the tension levels in the laryngeal muscles?
No, that's not really my thing. Tell me a bit about it, Emma. What do you do?
Well, so we haven't got an assessment clinic per se with a scope set up at this point, but of the patients that and I know we haven't been seeing patients face-to-face routinely very much over the last year, but prior to COVID and when I was assessing patients, doing a hands-on assessment, I would say 9 out of 10 of the patients, they've got heightened laryngeal tension at rest in the, like, externally around the neck and shoulders, and also jaw. Just wondering what your thoughts were about that, that's all.
Yeah, so that's interesting. So I don't know much about, and these are adults, I take it.
Yes, sorry, adults only.
Yeah, it's interesting. I really don't know much about it, but let me share with you. How much time have I got, Vicky? Can I share with you some?
Good 5 minutes, Ravi.
Fine. And if there are no more questions, let me share with you this idea, which might, I don't know if this is helpful. I think it's really fun. So I said I was going to talk about the autonomic somatic shift and what that means. And I think about this, right? Supposing you're walking on a straight line that's on the ground, okay, as a task of balance, right? Anybody can do this, right? It's easy. You walk on a straight line. If you're not drunk, you'll do it. Okay. So supposing the line is now on the top of a building side, how many people here feel like they'd fall over? Well, the answer is most of us. And the question is why? Why is walking on a top of a building much harder than walking on the ground? And the answer is to do with consequence awareness. There's something about consequence awareness that means that doing something that's relatively easy has become difficult. Now, the reason that walking on the line is easy, I think, is because we're doing this, we're just using our sense of balance without trying to work too hard at it. But when we are on a rooftop, we're suddenly trying to control our balance, which is largely autonomic. The same thing happens in old people. When old people have a fall, you can measure their balance score on a sway test, and then once they've had a fall, if you measure their balance once they've recovered, their overall balance scores are much lower. The reason that's happening is that they're now trying to walk without falling. So they have wrestled the autonomic control of balance into the somatic, and somatic balance isn't as good as autonomic balance. And this is what's happening on the building side, on the top of the building side. Because of consequence awareness, you're wrestling control away from the autonomic into the somatic. So consequence awareness does that. Now, neurosis and anxiety, what they are ultimately is all about heightened consequence awareness. And I think that what's happening at the level of the chords maybe is that our chordal movements are meant to be autonomic. We're not really, we kind of have voluntary control of them. I'm controlling my vocal cords now, but the way my vocal cords are meant to be moving with my breathing, I'm not meant to control that. It's meant to happen autonomically. But maybe my fear of choking, my heightened consequence awareness to choking, means I'm trying to wrestle control out of the autonomia into my somatic to try and control my vocal cords. And maybe tension within my larynx is a manifestation of that. I'm working against my larynx rather than working with it. And the reason that that's not going to work for me is that it's just too difficult. It's an autonomic function. I shouldn't be trying to do it. So I'm just wondering whether the muscle tension that you're seeing might be this autonomic somatic shift where we're trying to control where our vocal cords are in time. We're not meant to do it. We're just meant to get out of the way. Maybe does that help? Or maybe that's just the exact opposite of what you were thinking. I don't know.
I think that makes perfect sense. And I think Fiona's comment just saying, you know, I love the way that this has been delivered with such explanations as this, Ravi. That's a lovely example and really makes sense. Yeah, thank you.
I think that's a really great answer. Thank you. It just made me think about it all really differently, from a different perspective, which is really helpful.
Thank you, Emma. Oh, Ishan, is that you? Do you want to make that comment?
Yeah, hey Ravi. I was just going to say that the pathophysiology that you've described is quite similar to something in the audiovestibular world, the persistent postural perceptual dizziness that we talk about, or what used to be called functional dizziness, where you got functional, physiological, and psychological elements that play together that are coming together, causing the problem itself. So I just wanted to mention that as well. Sounds great. Thank you so much.
I think that's all the questions, Ravi, and that's perfect timing. We're a couple of minutes off 8. I think there's quite a few interesting Euro 2020 matches on in a couple of minutes too.